Well, I'd like to thank the organizers for inviting me. I'm here to talk this morning about thick glomerular basement membranes, or etiology and significance. So we're going to look at I don't know if you can dim these lights just a little bit. The GBM composition, the normal thickness and how you measure it, which I'm sure everybody in this audience already knows. Different etiologies of thickened glomerular basement membranes. I know there was a big talk about podocyte infolding glomerulopathy yesterday, so just a brief mention of that, and then the significance of thick GBM. Normal glomerular basement membranes are predominantly composed of type 4 collagen, as I'm sure you all are aware, with some laminins, glycoproteins, and heparan sulfate proteoglycans. The type 4 collagen in the GBM is mostly produced by podocytes with the alpha 3, 4, and 5 chains. But a small amount seen here so if I can get this to work, in the red is produced by the endothelial cells, and that is alpha 1, 2 chains of type 4 collagen. So we actually have two different types of type 4 collagen in the GBM, the majority of which is made by podocytes, the alpha 3, 4, 5 chain type. The normal GBM has a smooth subepithelial surface with a uniform medium electron dense lamina densa, as you're all aware, and then the lamina rara interna and externa, which are usually quite subtle unless there's some abnormalities. And you can see here the nice discrete podocyte foot processes with the smooth outer contour of the glomerular basement membrane. To measure the GBM, of course, you want to measure from the endothelial cell plasma membrane to the podocyte plasma membrane. So you're measuring the lamina densa as well as the lamina rara. The normal range in this nice paper by Mark Haas reaches adult thickness by the age of 9, and there is a range. So you can see it's 230 to 430 in males and a little bit less in females. But the average is about generally 320 to 340 in women and 340 to 360 in men. Your lab will probably vary a little bit. And there have been stereological methods for measuring these to determine the general thickness in a normal GBM. But there are ways you can do it where you don't have to do something as cumbersome as that. In this study from UltraPath in 2003, the GBM thickness was measured only 5 points in each loop and found the normal adult range 300 to 400, which of course is right within the range that Haas found. And in this other paper from BMC Nephrology, more recently, they looked at 16 measurements per glomeruli, 2 glomeruli per patient, so 32 measurements. And they did some correction for the non-perpendicular sectioning, but if you just want to look at it and not do the corrections, they came up with an average of 314 to 389, which again is right smack within that range that's considered normal. So really, if you just look at GBMs where they're not tangentially cut and they don't, clearly they're not at a curve and they're clearly not skewed, then you can just do a direct measurement and get something that is accurate enough for general diagnostic work if you're not doing, a specific research study and asking a specific question. There is a Renal Pathology Society consensus definition of what is thickened. And of course, the thickness, when it gets thicker, is mainly due to increase in the lamina densa. Generally more than 2 standard deviations greater than the mean thickness in age and sex match individuals. And you can see here normal at the 345 to thickened at 574, and then 642, 924, and 1260. These are all taken at the same magnification, and you can see. One way to think about it is if you have a normal GBM thickness, it's about the same width as a foot process, if the foot processes are discrete. So if you look at the 345 one up here, you can see that the foot processes are about the same width as the thickness of the GBM. And as you go down, say to the 924, if you look at like this discrete foot process right here, it's certainly much thinner than that thickened GBM. So that's just a way to get a sense if for some reason you can't measure it. But of course, all the scopes now, you can measure these directly. Thickened glomerular basement membranes may be focal or diffuse, segmental or global, depending on why they're thickened and what the underlying etiology is. There is a number of different lesions or diseases that result in thickened glomerular basement membranes. The majority of these are related to metabolic disturbances and hyperfiltration, although vascular disease, again with hyperfiltration and ischemia, can also cause GBM thickening. So we'll briefly walk through these. I'm not going to review genetic disorders or immune complex disease because that will be covered later in this session. And interestingly, many of these have overlapping mechanisms, which is not really a surprise because they all are related to either metabolic disturbance and or hyperfiltration. Diabetes, of course, as is already mentioned. I know Dr. Howell talked about that earlier this morning, has the thickened glomerular basement membranes. But what is interesting is that these thickened GBMs can occur in very early diabetes and can precede clinical abnormalities. So if you look here, the GBM thickness in early diabetes is an average of 427. In long-term normal albuminurics is 500. This is an old paper from Mike Mauer's group. And in microalbuminuria, it's about the same as in long-term normal albuminurics. So you can have this thickened GBM without the clinical manifestation, and that's important to recognize. And then as you get more overt proteinuria, you get an even thicker GBM. And there is a correlation between thickness of GBM and the amount of proteinuria. There's structural functional correlation there. In the classification of diabetic nephropathy by the Renal Path Society sponsored paper back in 2010, class 1 diabetes is just thickened GBMs without any other changes, no increase in mesangial matrix. And again, this is using the Haas definition with a GBM of greater than 395, this average in females and greater than 430 in males. And again, thickened GBMs may precede clinical diabetes. There's another paper demonstrating that. The GBM of thickened glomerular papillary basement membranes. And these are all patients who have no proteinuria, no albuminuria. And if you look, they don't have any mesangial hypercellularity, no nodules, but they do have thickened glomerular basement membranes. In this study, they found that 70% of those who had thickened GBMs went on to develop clinical diabetes over 2 years, and this was not associated with smoking or hypertension. So it can even precede clinical diabetes, not even necessarily proteinuria. So it can be pre-diabetes where you can see this thickening of GBM. So it's important to bring this up in reports so that the clinician is aware they need to follow the A1Cs and see if this patient's become diabetic. There's a number of different mechanisms of GBM thickening in diabetes. The one that's you would think would be unique to diabetes, but really isn't, as I'll point out later, is advanced glycation end products, which are produced in the diabetic milieu. And these can attach collagens and can glycate the collagens. This, in return, can alter the spatial distribution of the components of the GBM, can stabilize the cross-linkage so that the GBMs become much stiffer and more stable. It also can injure endothelial cells, and they'll make more of the alpha-1,2 type of the type 4 collagen. The hyperglycemia in and of itself, irrespective of advanced glycation end products, can upregulate the production of type 4 collagen by both podocytes and endothelial cells. And interestingly, it downregulates matrix metalloproteinases and causes reduced efficiency. So we have decreased degradation, and it upregulates the tissue inhibitors of metalloproteinases. So you have decreased degradation along with increased production, leading to thickening of the GBMs. In early diabetes, you also get enlarged glomeruli with mechanical stress and podocyte stress, which then causes podocytes to make more GBM. And this hyperfiltration causes increased production of your angiotensin II, with your renin-angiotensin system or your RAS upregulation. And this can also result in local inflammation and remodeling of the extracellular matrix, along with increased TGF-beta signaling, which also increases extracellular matrix production. So all of this results in abnormal collagen with this glycation, with increased production, decreased degradation, and you can have desynchronous matrix remodeling as a result of this, where particularly in diabetes, you can get this very funny texture, this layering, as you can see there, where it can almost look Alportian with some kind of irregular texture, although you'll notice that the subepithelial aspect does not have scalloping. But this irregular texture is a very common finding in diabetes, and I actually use it to help me suggest to the clinician it's maybe a diabetic lesion instead of one related to another cause of GBM thickening. Obesity has a number of effects on the kidney. Now moving to a different cause of GBM thickening. You get enlarged glomeruli, as you do in early diabetes, hyperfiltration, and thickened glomerular basement membranes. And obesity often is associated with diabetes. You have people who are obese are at higher risk for developing diabetes, and they also often have hypertension. So there can be multifactorial reasons for thickening of glomerular basement membranes. And you can see here these two glomeruli are photographed at the same magnification, and you can see one is really double the size of the other, with the difference in the BMI. Here are thickened GBMs and obesity-related glomerulopathies. So you can see normal weight, normal GBM thickening, BMI of 38.7 with a GBM of 815, and then a higher BMI with a thicker basement membrane. Notice how the foot processes are well preserved. So thickened GBMs do not always mean foot process effacement. It depends on injury to the podocytes. Irrespective of something like minimal change, remember in diabetes, you get damage to the podocytes because of the hyperglycemic milieu and so on. So looking at, you do not always get foot process effacement of thickened GBMs, and that's something to bear in mind if you're looking at an EM from a patient who has heavy proteinuria. The mechanisms of GBM thickening and obesity have some overlap with diabetes, but some differences. There is glomerular hyperfiltration in both. So again, you get this podocyte injury, abnormal RAS production, your ECM remodeling, your TGF-beta upregulation. But there are also unique factors related to metabolic and hormonal factors and lipotoxicity. So you have increased leptin and decreased adiponectin. And these are pro-inflammatory within the glomeruli and augment TGF-beta signaling and RAS dysregulation. You get oxidative stress because of this, and this can further damage podocytes, which will then make more type 4 collagen and endothelial cell dysfunction. So you get more of the alpha-1, alpha-2 chain type 4 collagen. And again, similar to diabetes, you get upregulation of production and downregulation of degradation. And you can see all these different factors that go into the thickening of glomerular basement membrane and glomerular injury in patients with diabetes, with hyperfiltration, your RAS dysregulation, and diabetes when it co-occurs with obesity. Low nephron number is another setting in which GBMs are thickened. There are many different etiologies that can result in low nephron number. There can be the intrauterine environment where there may be maternal malnutrition or certain medications that can cause impairment of kidney development during pregnancy. There can be genetic disorders. You can have PAX2 mutation giving you oligomeganephronia. Of course, if you lose renal mass, if you have a single kidney or one is taken out, or you have severe chronic kidney disease, then you get a reduction in functioning nephrons, and the remaining ones will react as in a setting of low nephron number. In the setting of low nephron number, you get glomerular hyperfiltration, you get increased mechanical stress, you get compensatory glomerulomegaly, and all the things that go along with that. In the setting of low nephron number, you can that thicken GBMs, but not always. So it's a little bit different than obesity and diabetes in that there are fewer mechanisms promoting thickening of the GBM. But if, of course, the patient has obesity and or diabetes in the setting of low nephron number, that's quite additive. So sometimes you'll get patients, say, with BMI 35 and they have completely normal glomeruli, and they have someone else with a BMI 35 who has big glomeruli, thickened basement membranes, and that second patient probably has lower nephron number, maybe 300,000 per kidney instead of 1 million. Smoking-related glomerulopathy, I think, is a really interesting lesion. It looks almost identical to diabetic nephropathy. You can have diffuse and nodular matrix expansion. You get thickening of the glomerular basement membranes. There's a little bit of difference in the microvasculature within and around the glomeruli, but otherwise it can be virtually identical. You can even get afferent and efferent arteriolar hyalinosis in smoking-related glomerulopathy. And this occurs secondary to toxic and hemodynamic injury. There's oxidative stress, TGF-beta activation. Really interesting is the fact that the toxic effects of smoking can result in formation of advanced glycation end products, just like in diabetes. And this may be partly why smoking-related glomerulopathy can mimic diabetic nephropathy. And of course, you get your activation of your RAS. So these are very similar. And by EM, you really can't distinguish them, but you can see thickening of the basement membranes and then, look at the patient's history. Was this patient a smoker? Are they male? Are they older? Do they have a history of hypertension? These things that are related. And then, of course, you can suggest that be considered in the differential diagnosis. Long-standing hypertension causes hemodynamic stress and glomerular hyperfiltration, again with mechanical stress, and really it's barotrauma with this podocyte injury, the changes in the RAS, the increased TGF-beta, and again, dysregulation of the matrix metalloproteinases. In long-standing hypertension, you will often get wrinkling and corrugation, as I think you saw in a section earlier today. Of the GBMs. So you'll notice in the diabetes, obesity, and thickening without hypertension, the GBMs are very open. The lumens are very open and the GBMs are very smooth, whereas in long-standing hypertension, they often are quite wrinkled in addition to thickened. And that's one of the clues you're dealing with ischemic injury rather than one of these other mechanisms of thickening of the GBMs. Aging in and of itself causes thickening of GBMs. So I'm sure a number of us here have some thickened GBMs in our glomeruli, myself included. There's altered collagen composition. The assembly is a little bit less organized as the cells age and some of them become senescent. You can actually get podocyte loss and drop off, and with reduced podocyte numbers, the ones that are left are signaled to work harder and they can make more type 4 collagen. Interestingly, aging in and of itself causes slow accumulation of these advanced glycation end products. We all have these made, and they can slowly accumulate over time. And if you live long enough, you'll have a whole bunch of them. So this can be, again, similar to diabetes, like a class 1 diabetes, where you just get this thickening of the GBM without the mesangial matrix expansion. And this is, of course, can be augmented if, in addition to being old, you have diabetes or smoke, you have hypertension, you're obese, or you were born with not very many nephrons. I'm really not going to go into podocyte infolding. I know there was a lovely talk about this in detail yesterday. As you know, there is podocyte cytoplasmic invagination, although as I understand, maybe not always. But in the cases I've seen, you get this invagination with entrapped cytoplasm, with this microcellular and microparticle inclusion. And here you can see nice examples of the podocyte infolding, and then what to me looks like entrapment, particularly here where it looks like it's coming in and getting entrapped. But this can result in these very thickened GBMs. There's no immune complex deposits frequently. You can see this very weird sort of layering, irrespective of these little inclusions. Notice how in the bottom right, that GBM is very layered and very peculiar looking. And so that is something to be aware of when you see this, that it's not just these little inclusions, but the GBM itself is not only thickened, it has kind of a very regular structure and texture to it. And as I'm sure was discussed yesterday, this often is associated with lupus or collagen vascular disorders. But if you notice here in the purple, there can be quite a number of cases where there's no underlying disease that has been reported. And if you look at it with respect to electron-dense deposits, the majority of them really do not have associated electron-dense deposits. And down here are the ones that are isolated without deposits, and more than half of them are of unknown etiology or unknown association. And we really don't understand why this happens. It's been suggested it may be related to in situ complement activation. There was a nice paper that showed dysregulated cytoskeletal protein alpha-actinin 4 and tubulin beta-4 chains. So it may have to do with how the proteins are not being, that it's in the podocytes, so the podocytes may be making not only an abnormal collagen, they may be dysregulated so they don't maintain a normal shape, and then they come into the GBM as the GBM thickens or is damaged by the other, if there's a related underlying disease. And then mutations in INF2 and SMRCAL1 have been identified. Again, these are podocyte mutations that have to do with podocyte structure. So maybe there's structurally something about the podocyte that allows it to do this, given a certain second hit like lupus or diabetes or something else that we don't understand. What about the clinical significance? Well, this has really only been looked at in diabetes, although I think it would be of interest to look at it in obesity and in smoking. In this paper from 2018, they divided biopsies from patients with diabetes into those that had GBMs less than 787 nanometers and those that were greater. And you can see that the renal survival was significantly less in those that had thicker GBMs, starting at about 3 years after diagnosis. Looking at this a different way, the time to renal replacement therapy, if you look at the glomerular factors here, when they looked at the different glomerular features, the only one that was statistically significant with respect to prognosis for time to end-stage kidney disease was the thickness of the glomerular basement membrane. And in this study from Jason in 2013, from Mike Mauer's group, they showed that they looked at structural parameters of progressors and non-progressors in diabetes and found that the only one that was significant was the GBM width, where non-progressors it was about 416, and progressors it was 567. So it's important not only to say that the GBMs are thickened, but to say what the thickest GBMs are, because this may have an impact with respect to patient prognosis, outcome, and time to end-stage kidney disease. So in summary, thick GBMs occur in association with a number of glomerular lesions, and they're observed in enlarged glomeruli, regardless of the reason for enlargement, although again, if it's low nephron number, that can be variable, so it can be additive if there's other effects like lipotoxicity, metabolic disturbances, and obesity. These all pretty much have overlapping etiologic mechanisms, including glomerular hyperfiltration with enlargement, podocyte and endothelial cell injury with aberrant GBM production or organization, and glycation. So it's not surprising that these different lesions all have thick GBMs. There are mimickers of GBM thickening, including podocyte infolding and other abnormalities that will be reviewed later in this session. And they do have prognostic significance in diabetic glomerulosclerosis, so I do think it's helpful. And I always report what the thickest GBMs are, just so that information is available. And I thank you for your attention.
We get to questions at the end.
Yeah.